Good evening and welcome to one and all. We are here again with another very relevant topic, shared governance in nursing, empowering the front line. And we have got a very brilliant moderator today, Dr. Elizabeth Joseph. Dr. Elizabeth has more than 30 years of experience in nursing care, patient safety, nursing education, quality, national and international accreditations. Dr. Elizabeth is currently the Chief of Nursing and Head Quality, Wockhardt Hospitals, Mumbai. Dr. Elizabeth has got a brilliant academic record after BSc, MSc, and then the prestigious PhD from JJTU, Rajasthan. In addition to all these, Dr. Elizabeth has another diploma in hospital administration from Tata Institute of Social Sciences, Mumbai. Not just in the academics, is also an NABH assessor for so many years. And Dr. Elizabeth is was very active in the drafting of the 5th edition standards of NABH and the nursing excellence standards. Dr. Elizabeth is an award winner at various national and international platforms. So I welcome Dr. Elizabeth to this CXO Roundtable, initially to welcome your co-panelist and then to moderate the session. Dr. Elizabeth, over to you.
Father Johnson, for that very nice introduction. I would like to introduce my panelists. The first panelist, Dr. Karen Keady, who is Vice President and Chief Nurse Executive, University of Rochester Health System. In her capacity, Karen provides executive system leadership for nursing and clinical support staff at Strong Memorial Hospital and affiliate hospitals. In this role, Karen has focused on standardization and collaboration across the health system, analyzing opportunities for optimizing infrastructure and resources, improving patient and staff safety, harmonizing technology, and developing leaders. Over the last 2 years, she has led strategic initiatives to successfully navigate the COVID-19 pandemic, including implementation of new nursing care delivery models, designing creative incentive plans to improve staffing, novel approaches to training, and enhancing shared governance models. Prior to joining the university 4 years ago, Karen spent 30 years with Johns Hopkins Health System. Her clinical nursing background is in neuroscience critical care, and she has held several leadership roles with the health system, including nurse manager of the cardiac care unit, director of medical nursing, and chief nursing officer. After receiving a bachelor's degree from Towson University, Karen earned a master's and doctoral degrees from Johns Hopkins University School of Nursing. Karen is an international speaker, consultant, and published author in the fields of heart failure, self-care, cognitive impairment, and leadership and professional development. From 2014 to 2016, Karen served as a consultant through Johns Hopkins International to provide leadership development series for nurse managers at Sir H.N. Reliance Foundation Hospital and Research Center in Mumbai. Karen is board certified as an advanced nurse executive. Welcome, Karen, to the panel.
Thank you. Thank you very much. Happy to be here this morning.
Our next panelist, Ms. Pearl Cruz, who has 18 plus of years of experience to her credit. Pearl is currently working as Chief of Quality and Patient Safety at Sir H.N. Reliance Foundation Hospital in Mumbai, has led the team and is also leading the team towards JCI accreditation. Pearl was a chief nursing officer at Apollo Proton Cancer Care Hospital, Chennai, has won the Nursing Excellence Award for her team. She has worked in the capacity of the CNO for Gleneagles Global Hospital, Mumbai, where her QIP, a quality improvement project selected by NABH for National Quality Conclave, was presented. Pearl has also had a stint at Wockhardt hospitals. She has many achievements and awards to her credit, and there's a disclaimer that she has put that all the projects that she has won is an effort of a teamwork. That talks a lot about Pearl because I know her at a personal level and she's a most humble person that I have seen. So she's got the Times Healthcare Awards 2020, Excellence in Quality and Patient Safety, Midday Iconic Hospital for Quality and Patient Safety 2020, National Quality Conclave Delhi 2018, where there was an oral presentation on use of quality tools for reduction of IAD, ISQA London Conference 2017 and ISQA Tokyo Conference 2016, where she spoke about nursing quality projects selected for presentation, Kimpro Convention 2016, where she won the Quality Fable on Quiet Time, Kimpro Convention 2012 for a quality project on bedsore management, Asia Hospital Management Award for a quality improvement project on pain management services. And this, Pearl, is totally to your credit, the University Gold Medal for standing first in MSc. Pearl is a writer. She writes articles on healthcare quality, children's fiction. She loves reading, sketching, and mountaineering. She's also an entrepreneur and has, to her credit, an established children's daycare and children's magazine publication, which is a Child City. Welcome, Pearl.
That was quite an elaborate introduction, ma'am. Thank you so much. I think half of my achievements that you mentioned, I need to give credit to you because half of them, probably most of them I've achieved whilst I was working under your leadership. So thank you for a wonderful introduction.
Thank you, Pearl. And our last finalist, Dr. Viji George. Dr. Viji George is a change management system healthcare leader and leader mentor who works as clinical excellence program manager and magnet program director at Texas Health Resources, a multi-hospital Fortune 100 healthcare system in North Texas, US. Dr. George's career includes role as military nursing officer, nursing educator, clinical instructor, staff development administrator, and certified neonatal nurse. She actively participates in and promotes clinical excellence through evidence-based practice, nursing research, shared governance, and professional development in the hospital system. Her doctorate in nursing practice is focused on nurse executive leadership. She is an EBT fellow, a current fellow in Health Science Research Fellowship Program, and an AMN Chief Nursing Officer Academy alumna. Viji has done professional publications, has presented in national and international forums, sharing best practices in healthcare and professional practice. Her professional passions have led to international ventures, such as becoming Sigma's International Leadership Succession Committee member and Global Leadership Mentoring Community mentor. She co-founded Indo-American EBP Fellowship Academy through collaboration with Johns Hopkins Nursing EBP. Her accolades include awards such as DFW Great 100 Nurse, Nurse Excellence in Leadership, and Visionary Leader. Welcome, Viji, to the panel.
Thank you, Dr. Joseph, and thank you, CAHO, for this opportunity. Good to be here with such a great panel here.
If one has to go back in history in nursing, you would find a very humble and simple beginning and some mention about nursing way back in 476 AD, somewhere after the collapse of the Roman Empire. It is interesting to trace back to the roots of a profession that today has evolved and advanced. The advancement could vary from country to country, doesn't matter. Because of technology and because of organizations such as CAHO and Father Johnson, we have people sitting here today sharing a platform across the globe talking about some of the challenges they have had, how have they adopted this model, how is it beneficial, and to the listeners, I'm sure at the end of this 1 hour, we will definitely have some takeaways. Over a period of time, nurses have tried and tested many models for delivery of care. The foundation has always been safe patient care. Easy or difficult, probably it is for us to replicate it in our system, in our country here. Before I get back to the panelists, I would request all audience who are here with us to keep sending your questions to the Q&A icon that you see at the end, at the bottom of the screen. So to begin with, Karen, I would just want to understand the genesis of this entire model. We've been talking about the shared governance model. What is the genesis of this model? What brought about this model into nursing practice? And what are some of the guiding principles on the basis of which this functions?
Sure. Thank you for that question. And I think it really, I've been working in healthcare for, 35 years. And my first experience with shared governance was back in the 1980s, where I think that's where things started, where nurses really wanted to have a voice and they wanted to have autonomy over their practice. So I really think that's where it started, where professional nurses were becoming highly educated and really wanted to have a governance structure that allowed them to have input into the decisions that hospitals or clinical settings were making about nursing practice. So I think that was the foundation. And then that has evolved over the years to different models, because, it's one thing to say we want shared governance, we want autonomy over our practice, we want to have a voice. But then we really have to put the structure in place to be able to have that ability for nurses to have input. And that's really the hard part, I think, is establishing what that structure looks like. And I think there's different models, so it's not a one size fits all. I think an organization has to look at how they want to put that in place, asking the people who work in that situation what would work best. So here at University of Rochester and at Hopkins, when I worked there, we had very robust shared governance models that had evolved over the years. So probably 30 years worth of working at this and changing them as you go along. So I think whatever we put in place initially has completely changed over the years based on nurses coming into the profession, evolving with education and professional certifications and other things that have really changed the face of and the scope of practice for nurses. So that's my kind of advice for organizations who are looking to launch a shared governance model, is that it's a very grassroots process and has to involve the frontline, as we call them, nurses, because they're the ones that know what will work for them. And I know we'll get into some of the other conversations about the pros and cons of this model, but clearly it is a challenge. But when you have it right, it definitely gives you a vehicle for better patient safety, better patient outcomes, but also a more engaged nursing workforce. And that, I think, is the foundation of shared governance, is really having nurses engaged in their practice and engaged in what they're doing, which translates to better patient care.
Yeah. Thank you, Karen, for that. As you rightly said, there are different approaches to this model. What I would request Dr. Viji, and she's somebody so passionate about governance, shared governance. I think over the last 1 week that I was interacting with her, I could actually sense her passion, though she's miles away from us. So Viji, can you describe to us what this model is all about and how did you go about? Because when I was reading your CV, I realized that you've implemented magnet as well as pathways in many of the hospitals. And this is a foundation on the basis of which you could do. How did you go about implementing this?
Dr. Joseph, yes, miles apart, but my heart is still Indian. I have had this amazing education from India and came, moved out. Life happened to Middle East, to US. So what I saw different here in US is that, my education is a part to work anywhere I go in the global world, like to work as a nurse. But when I came, especially to move to Texas, it was a magnet hospital, and I started as a clinical nurse. I moved from leadership to being in a clinical nurse, and I realized it's something different. Every nurse seemed to be a leader here. Every nurse seemed to have the power to make decisions in the patient's care, in the staffing, or in the decision-making. So it seemed like a shared decision-making. And within a few years, like I got to know the system and understand, became very involved with the magnet clinical excellence initiatives, and soon got like, maybe I could understand like this is the grassroots of what it is, and became the magnet champion. Is there, and this all became clear to me. What is the difference for the magnet hospital? Magnet is an accreditation for nursing and clinical excellence. But one of the key component of that is shared governance. What shared governance model looks like is like Donabedin's structure, process, and outcome model. So you have to have a structure for people to come together for practicing shared governance. So shared governance basically is a partnership between leaders and frontline to come together to seek solutions for, be it safety, quality, patient satisfaction, any outcome, and staff satisfaction. It's very important. Like that word says that magnet hospitals attracts patients, attract staff to stay there. So when you have a structure to practice, so that's like at the grassroots level, you have to, every unit has to have a unit-based council. Together, these council go to a bigger council in the hospital, and we call the shared governance council. And I can talk about it a bit later about the structure, how we implement it. And that structure go to a system. As I said, our hospital is 24 hospitals. 19 hospitals are either magnet or pathway to excellence. So accredited because of these efforts at the grassroots level. We have to know that nurses are not trained to be leaders, right? We are trained as caregivers. We are there to give care. Now, how do you encourage the nurses to be leaders and making decisions, conducting these meetings where they all come together? Not everybody can participate, very engaged. The nurses who really want to make a difference, like, those who want to go a step above. So here is your opportunity. You come together through unit-based council, you make that process of shared decision-making. And what is the outcome? The outcome is shared governance. That's a shared leadership. So that's what is a basic of the structure, process, and outcome model that we follow here at our hospitals.
Thank you, Dr. Viji. I think that gives a lot of clarity, because I think many of us are familiar with the Donabedian model, and very beautifully you actually explained how shared governance fits into that model, the structure, process, outcome model. Coming back to our own country, Pearl, what is the status of the shared governance in our country?
I'm glad that nowadays the questions have changed from status of nursing in India to status of shared governance. Thanks to probably a major part of the pandemic, and also platforms like CAHO and the NABH and JCI, and because of this, probably the status of nursing has been uplifted to a far extent in India. But yes, having said that, shared governance, I think, is a concept which is in a very, very nascent stage. And people are probably hardly anybody is getting awareness about it. But yes, I'm glad that we have such discussions that are happening where others are privy to it. When we have to very, in a structured manner, if I have to really evaluate shared nursing governance, there is a very specific tool called as Index of Professional Nursing Governance tool, which measures shared nursing governance. And I was very surprised when I was doing, my research on this topic about status of SG in India. There is, in fact, in Northern India, a study which was conducted among the nursing fraternity over there about the awareness of this particular model, And needless to say, yes, the score that was achieved was very low, which says that people still believe in decisions which are made by either the management of the hospital, the CEO of the hospital, and to some extent about the nurse leaders. Now, this particular model, the particular tool basically, tells you about 6 subsets, whether the nursing has control over the practice? Like, are they involved in policy making, in procedures, in care protocols? Influence over the resources? How much influence do they have over their own nursing manpower over there? Do they have control over their manpower, whether they can define and discuss how much nurses do they want, what kind of nurses do they want, how much do we enable our nurses? The fourth thing, it talks about the participation of these nurses in the committee structures. We all know that hospital governance structures are primarily sort of, to some extent, like a model of shared governance. How much does a nurse has representation in that, and how much of access of information does a nurse have? And finally, how much ability do we give our nurses to set goals and negotiate any kind of resolution that is required? And in all these 6 parameters, the scores were very, very low, because in India, we know, especially with the public health systems, we have this matron kind of a culture who is there, who reports there to the medical director. And that is how things are discussed. It's at the top. There is no bottom involvement. So the status of shared nursing governance, barring few hospitals who are aware about this and trying, their best to set up these kind of models, I think we are at a very, very nascent stage, and we have a long way to go for shared nursing governance.
Yeah, I think, Pearl, but the good side of it is it has begun somewhere. So I think that's something that we can, bank upon. And especially, as you said, platforms like this, and where we can gain from what the others have done. I think that can sort of fast track the whole thing. Just wanted to know, what are the pros and cons of this model? Now, can we comfortably say that this model can stand strong and brace any calamities? For example, we've just come out, or I should say we're coming out of a calamity, the pandemic that has hit us. And during the pandemic, we know the best of the hospital with the best of policies, best of protocols, everything seemed to go for a toss. How did shared governance model stand the test of time? What is your take on this?
We've already talked about, I think, some of the pros that we can say about shared governance. And, when you have that structure in place, we do see better retention, more engagement, more satisfied staff, but it also translates to better patient outcomes and then ultimately better financial outcomes for the organization. So, I think those are the things that we see beyond nursing, that when you have that working, when nurses are truly engaged and feel, that they have a say in what's happening, all those other outcomes follow. Some of the cons and some of the things that we learned during the pandemic were kind of eye-opening for me, because obviously none of us have done a pandemic before and we had to kind of learn as we went. But shared governance doesn't really work during wartime leadership. I mean, that's really what we were in, right? You have peacetime leadership and you have wartime leadership. Well, we were just in wartime leadership, where I had to make very autocratic decisions about how things were going to go, where people were going to work, how we were going to float people to where the needs were. And I really didn't have time to put that through a shared governance decision-making process, because frankly, shared governance takes time, right? You have to go through council structures. You have to have time for nurses to come away from the bedside and meet and talk about how they want their practice to go. And during the pandemic, I wasn't able to do that. So I had to make some really quick wartime decisions using very few people to consult with. And the nurses, they were okay with that because they wanted leadership during the pandemic. They wanted someone to act. I mean, that's what we want, right? Decision makers, people that are going to say, here's how we're going to keep you safe. Here's how we're going to run this. But we abandoned the shared governance model for a period of time when we had to operate in that way. And we're just now getting back to being able to, put those structures back in place and say, okay, we're getting closer to peacetime leadership now. We can start to decision make through the councils as we had in the past. And so I think, people, maybe the pandemic gave us a chance to really see the value of shared governance, because for a period of time we had to pause that. And I think people missed it, and they're really eager to get back to it now. And I'm seeing a much more interest in coming to our professional nursing council meetings, in participating in our sub-councils, and I'm delighted to see that. So, as we say, there's some silver linings to the pandemic. I think this is one of them that we really learned that the true value in shared governance is having people help me guide my decisions. And I use the Professional Nursing Council here as my advisory council to help me make decisions, give me recommendations on where we want to go as an organization, as a nursing practice group. And I value it much more now, having had to be very autocratic for a period of time. I'm much more comfortable being back in this model of using those frontline nurses, so to speak. And I think it's interesting how we use terms that are very war driven, like frontline, redeployed. And that has really got me thinking about how we have been through a wartime situation. And I'm delighted to know that we can come back to it. But I will say that some of those cons, the fact that it does take time, and there is a financial investment that has to happen because you're asking nurses to come away from the bedside, participate on these councils, and the organization has to recognize the value of that and be willing to invest in that, because you really have to give them that protected time to be able to participate in those things. So as far as cons, I would say that's one of the biggest ones, is figuring out how to get the time for these nurses to be able to participate in this work.
Yeah, Karen, I totally agree with you. I think pandemic has really taught us to value a lot of things, personal as well as on the professional front. It's only when pandemic things like this hit us, we realize what we enjoyed was something different, and we all crave to get back to that normal. So it's good that your team and you are happy to get back to the governance model. So any question, when you introduce some model, or when you introduce any new sort of a product or a sort of a system to the nurses, the first thing that the nurses have in mind is, what is in it for me? How do I benefit? What is the benefit of having a governance model? So Viji, my question is, how does this model help a nurse in a day-to-day functioning? What is the importance of this model?
Dr. Joseph, very good question to say that what's in there for me, right? That's what motivates everybody. I feel there has to be something there for us, for others, and for a larger outcome. We all are part of making some big impact. When you are able to make that impact, you are vested. And when Dr. Keady mentioned about going away from shared governance during pandemic, our organization, I was surprised. I was thinking, there goes all these efforts of years down the drain. What is going to happen? But our shared governance leaders, our council leaders, these are the clinical nurses, the frontline staff. They adapted to the change. We were not able to meet every month, but we made, if there is a high census, if there is a crisis, we cancel those meetings, but we still made sure that adapted the technology. We adapted the technology to Teams and immediately started meeting like this. So adapting to something like that and still continuing a part of the decision-making was amazing. Even we were surprised the frontline was equally involved in the decision-making, be it the PPE distribution, how we manage, we were reusing the PPEs at that time. The masks were used, N45 was not available. So it was the staff was trying to see what's management trying to do. And here we are okay with that. But how long? So every time that voice was heard. Second thing was that when these meetings were happening, they brought some ideas like team nursing. So it was when this team nursing was introduced, the staff also we are ready to get trained, to float, to go and help. I'm not ready to say my background is clinical nursing in neonatology. I cannot go and work in an adult ICU, but how can I go and help my ICU nurses? They are, in their PPE, taking care of the patient. Can I do something outside the patient's room? Even in management, people were going and helping with stocking the PPEs. We were just using like anything. The staffs were so busy, the management came down to the floor. So those are the things was a power of shared decision making through shared governance. May not be able to follow exactly, but when I look back, we are required to say 80% meetings, 10 out of 12 to meet every month, like in 2 months you can go off. But when I counted, it was 7 meetings still happened during those pandemics. Now, when you say about what is in there for me, what is the purpose of each nurse is going to get out of this is the basic principles of shared governance. You are going to get the shared partnership with your leadership in the decision making. So you know what's happening. The decisions are not made in the boardroom. The decisions are distributed to everybody. There is a voice of the frontline heard by the board. Second thing, there is the autonomy. You have the autonomy of your own professional practice. That's how only nurses know what's happening in the nursing world, not the medical or any other auxiliary department heads, or not the board members, executive leaders who may not have any clinical experience. The next thing that I feel that is important about is it encourages accountability. Accountability is that this is my work, what I do, and what is not working for me, I have a voice to talk about it. And finally, what I feel is that equity, it brings equity to everyone in the hospital's management. You know, why do we go to hospital? So one of the things that I started saying that if you need a medical care, so when we have surgical centers, you know, the day surgery happen, you can go home and take care. Someone can come and visit you in the home and take care of you. If you need medication, you can go to the clinics, get the medication. Why do patients go to hospitals? And hospitals, who are the most in the hospital? The biggest crowd that is in the hospital are the nurses. So patients go to the hospital for skilled nursing care. Any care can be given, but can the care be given in the skilled without the skilled nursing care? You need ICU care, you need ICU nurses. You need OR surgery and all those things done, you need OR nurses. Neonatology, you need neonatal nurses there. So that concept is that I am very important in my work for a greater outcome for what I signed up for. A lot of people go to nursing because they want to take care of patients, right? Money making is a byproduct of it. If you're going to the healthcare for making money, you will be there for a few years. You will not sustain. What keeps you coming back to work is I am making a greater impact for that. So that's the power of shared governance. That's the power of me, or as a nurse, how can I impact in those decisions? And I'm telling you this because I worked as a clinical nurse. I was on the other side. I was able to implement many evidence-based practice projects that made changes in policies, that made changes in practices. So I have experienced that. Eventually was participant of a unit-based council member. From there, moved on to be the participant in the magnet, and then system level, and soon and this level in the system level leadership position. So another win for nurses, how do we engage people? How do we motivate is by having the more the nurses are involved, is there a gain? You know, I want to do my 8-hour shift, 12-hour shift, work and go home. But if I'm going to have a ladder, so we have a clinical ladder system. So level 2 is you have some experience, but for level 3, level 4, we got up to level 6. Each level requires higher education and higher involvement in patient care activities. So these are some of the things that is there, and each level also gives some monetary benefit, like, you know, a few dollars extra for each level. So because of your participation, you get to see the impact and you're also making money. So these are some of the things that will encourage nurses to get involved in shared governance. Thank you.
I think that was interesting. We're talking about the same model, and Karen had something different to talk about her experience with shared governance and pandemic, where Karen said she had to put this aside and get into an autocratic role. And I fully well relate to it, because probably the entire decision-making process would take long, and pandemic didn't give us that time. There are certain decisions which I felt I could have done it. Yes, if I had done it yesterday, probably today would have been better for me. And Viji is talking about how the shared governance model adapted to the pandemic. So 2 different perspectives, very interestingly put in. And also the fact when the nurse asks, what is it for me? I think every nurse would love to come to work with the aim that I am going to make a difference in the life of someone. There is a career path for me in this organization. And yes, who doesn't love to have monetary benefits? So coming back to Pearl, what are some of the challenges you faced while implementing, or, if you have to put in place a shared governance model, what are some of the challenges you think you're going to face, Pearl?
Honestly speaking, I've been very fortunate in both the organizations where I was, part of this particular model. One was in Wockhardt, and when I'm currently working over here as a chief of quality, we had decided to go for Magnet, and we're just preparing for it. And frankly speaking, there has been a lot of buy-in from my CEOs, from my CNOs for this model. But having said that, what are the common challenges that people do face when we want to implement a shared governance? I will just bucket it into, my 4 basic buckets of quality: man, money, method, and material. Right? Let's come to the man part of it. The first and foremost challenge for man is we ourselves, the nurses. Because primarily, if you go by the academics or curriculum of nurses, like Viji rightly pointed out, in India, nurse is not thought to be a leader. She's always thought to be a person who serves the patient, who is a part of the healthcare system, who is there, somebody who is 24/7 at the bedside of the patient. She's not thought to be a leader. This particular thing is not set in her, and neither our hospitals do encourage that, because of the kind of culture that we still do exist in some of the hospitals. So that's one thing that they're not setting for. The second thing is the buy-in from themselves, because this particular model requires a lot of commitment from the frontline nurses, from the ground level nurses, because it is something beyond that they have to contribute besides the clinical care that they are giving. They have to think and be a part of, a shared decision making. So that's the second part. Awareness about this is something is still setting in, so that is something that we face as a challenge here. Thought process of the nursing leadership itself. People are not open to certain things. I don't think all the nursing leaders in India are accepted, accept this fact that I need to, bring my bedside nurses to the boardroom and sit with them and discuss how do we, think about the changes that can happen. The interprofessional acceptance from our doctors, from our other healthcare workers, from our support departments that we have in the hospital. Nurse has always been at the bottom of the pyramid, in the healthcare, which is changing now. I'm happy about it. That's part of man. When we come to the money aspect, tangible, non-tangible. Now, one thing is when I ask my nurse to be a part of the shared governance model, when I ask my nurse to be part of the unit councils and the various other councils that were put in place, I need to apportion that she's going to spend this extra time. It can't be part of her clinical time. So she has to be compensated for this particular time that she's going to give, because it does involve either you compensate by giving extra nurses when we calculate the manpower, or you pay her extra for being a part of this. It involves finances. Non-tangible things like, you can't just say, put a shared nursing governance model. It requires a lot of things. You require a boardroom. You require, the brand building that you're going to do around it. You need to advertise it. All this is going to cost, not a huge cost, but to some extent, yes. When we talk about the methods, when we were also setting up a shared governance model, when we were together, there were a lot of questions. How do we go about it? How do we align all our councils together? So to understand how to develop this model, it's important that we have collaborations with hospitals which have already been successful in this model. So that methodology of putting up a model is something which is not very, very clear. That can, if you don't use the proper method, you will not get the proper outcomes that you would like to. When we come to the fourth bucket of material or the resource of the environment, for shared governance, the environment has to be that of an empowerment. Shared governance is not just a model, it's a complete culture change. It's a culture change where you empower our ground level nurses to be a part of decision making. So that particular environment to get created itself is a journey by itself. So that's the final and the most important challenge that we need to overcome in the hospital. So the leaders at the top who are sitting in this, attending this session, Dr. Father, who is sitting in this session, and I'm so happy that he has taken up this session of empowering nurses, and I'm sure his nurses in his hospital probably would be enjoying this empowerment thanks to his thought process. So it has to there has to be a change of thought process in the top to involve the bottom. So the top down and the bottom top approach is very much important. So those are a few challenges that I anticipate when we set up this model.
I think Pearl very well put in. You put in those 4 buckets to give us a clear structure or clear outlook as to what are some of the challenges that we face. We've got about 5 minutes to go before we can take up the Q&A session. So, and this is the last round. Very well put in. You put in those 4 buckets to give us a clear structure or clear outlook as to what are some of the challenges that we face. We've got about 5 minutes to go before we can take up the Q&A session. So, and this is the last round of questions. So I would request you all to just keep it brief, and we can open up the Q&A sessions for the audience. Karen, could you quickly tell me, how does this fit in with the rest of the hospital? How do non-nursing professionals look at the shared governance model? Pearl has very briefly just told what happens in our country. Could you just share with us how does this model weave in with the rest of the hospital, and how do non-nursing professionals look at it as a value add to them?
Sure. Yeah, great question. And I think, we talk about shared governance in nursing, but certainly it could be adapted for any of our other professional groups, because I think we all would want the same things. I'm thinking about our respiratory therapists or our physical therapists. Certainly they could model after what nursing has done, and I think many of them do. I think the key here is being able to demonstrate the value proposition of doing this. And we can't just say, well, this works because the nurses like it. We have to be able to say, these have hardcore outcomes that you can, look to say to the hospital, especially your finance people, that, by doing this and investing in this, you can see lower turnover rates, which we know that translates to financial outcomes. And then we will survey the staff, and your staff satisfaction scores can be higher. That translates to better patient satisfaction scores. So you can have hardcore metrics, I think, that you can demonstrate for the rest of the organization to say that this investment pays off and I have tangible outcomes to look to. The other thing beyond those sort of organizational financial kind of metrics is take a look at your patient metrics and your nurse sensitive indicators, which are very significant to Magnet. We call out certain things like falls, pressure injuries, line infections. Those are all considered nurse sensitive indicators. When you have a really robust shared governance in place and those nurses are engaged, they're not turning over, you're not retraining people every few months, then you can really start to see those other outcomes improve. And those also translate to better reputation for your organization in the community. So, and obviously the Magnet designation, if that's what you're looking for. So I think all of those things, it's our job to be able to articulate them to the rest of the organization that this is something that they want to invest in.
Great. So Viji, would you want to add on to what Karen has said? What are some of the tips for successful implementation of this model? Karen has already touched upon. Would you want to add some more to that?
The tips for successful shared governance is, first and foremost, you have to have a vision, an overall vision, have a model, a structure of yourself, your organization. What is adaptable and best will work for your organization? I'll share my model. We have got 5 councils. The councils involved is the Leadership Collaboration Council. That's all the nurse managers and above all the nursing leaders come into that. So they promote the transformation leadership. Then we have the Clinical Excellence Council. So Clinical Excellence Council is looking at all these nurse sensitive data that Karen is talking about. So nurse sensitive indicators are the indicators that affected due to the nursing care. For example, falls or CLABSI, because of the nursing care, outcome can become bad. So the Clinical Excellence Councils look into that. The third council that we have is the Professional Governance Council. Professional Governance Council is an interprofessional team council. All the unit-based councils, chairs and vice chair come together to this one. So, and then we have the fourth one is a New Knowledge and Innovation Council. That's where new knowledges, evidence-based practices, and nurses are encouraged to do the researches at the bedside. So when all these things are coming together, someone has to overlook how these things are working, right? So overall, we have an overarching council that's called the Outcome Promotion Council. All the chairs, vice chairs, leader mentors of these councils come together to the Outcome Promotion Council. and they discuss how these councils are working well and where need to head using the hospital strategy. This is what our hospital strategy is, nursing strategies and operational requirements. And based on that, they set goals. The basic tip for a successful unit-based council is giving them a toolkit to work well. First thing we tell is each council to come up 3 SMART goals for a year. Don't try to solve the problem of the world. Focus on these 3 SMART goals of that council based on their council responsibility. Second thing is we have to have a structured charter. You cannot run a committee without a charter. Have a structured charter that will keep them on guideline. And number 3 is show them how to conduct meeting, because remember, these are frontline nurses who are running this. So we give them agenda template. Only 3 things they have to require: maintain an agenda, work with your leader, and use that agenda to have this like kind of a structured meeting. Second is have the minutes for that meeting, because we need require the documents, what we discuss. We don't want to come back to it again and again. And number 3 is attendance roster. Every council member is required to have 75 to 80% of attendance. So these are some of the toolkits we have developed, and we use the same thing for the unit-based council. So unit-based council, 20% of the nurses are encouraged to be in that unit-based council. So if you have a 24 to 30 staff in one unit, so it could be like 7 to 8 or up to 10 people who can be. So we have a chair, vice chair, secretary, all these are the frontline staff who are running these. So that's some of my contribution to this.
I think some really great tips, and some of them are like easily doable. I think as soon as the meeting is over, I think some of them can just get into it and, start implementing really great tips, and some of them are like easily doable. I think as soon as the meeting is over, I think some of them can just get into it and, start implementing them. Before we take, there are some very good questions that have been put into the Q&A box. But before that, one last question to Pearl. Last question to Pearl is, Pearl, after listening to Karen and Viji, where do you think we stand and how far you think India is from achieving a successful governance model?
I think, thanks to a lot of platforms, the Association of Nursing Executives of India, the accreditation standards, a specific nursing standard called Nursing Excellence by NABH. Because of all these efforts, nursing has somewhere started becoming visible in India. People can see that it is important for your nurses to be skilled, for your nurses to be involved in your healthcare system, for you to be a safe hospital. So I think half of our journey has begun because nursing has started becoming visible. The culture change is our next step. And I think probably, I can't put a period to it, but I guess with so many good things happening, I think probably by the time, ma'am, you and I decide to take a break from nursing, things will probably be very well set in India. And people are talking about magnet and pathway to excellence and all. I think at that time we'll probably be sitting and reaping the fruits of all this and saying that, okay, probably we had some contribution to this. So I can see that before we, go to the heavenly abode, and I'm sure things will all be in good stead in India. But I'm happy about the changes that are happening, and I'm so positive about it. Things will happen well here.
That's very encouraging, Pearl. So we have about 10 minutes and we will quickly go through some of the questions. One very interesting question. Do we have any objective measures to evaluate the outcomes of shared governance? I leave it to the panelists, whoever can take up the question.
I can tell that because we constantly measure that. There are various tools to measure that, but what helps us in being a magnet organization is
encouraging, Pearl. So we have about 10 minutes and we will quickly go through some of the questions. One very interesting question. Do we have any objective measures to evaluate the outcomes of shared governance? I leave it to the panelists, whoever can take up the question.
I can tell that because we constantly measure that. There are various tools to measure that, but what helps us in being a magnet organization is every year, as I mentioned, we have a national database. So number one thing is you have to have a benchmark, right? A national database, we call NDNQI, National Database of Nursing Quality Indicators. And there we send all our nurse sensitive indicators to see the outcome. So some of the requirements are there. We have to measure at least five nurse sensitive indicators that we are struggling. So that's regarding the clinical outcomes. Another one is job satisfaction of nurses. So every year we have RN survey, NDNQI RN survey is conducted. And there are 7 elements of RN satisfaction. You have to outperform 4 out of those 7 to be accredited as a magnet hospital. So you're constantly working to make sure that the nurses are not just doing things, but they are engaged and involved in meaningful. So when you are involved in meaningful engagement and shared governance promotes those job satisfaction answers. So that's how we measure.
Okay. So just to sort of give some semblance to what we are doing, I think Arish is the one who has posed this question. When we're talking about outcome measures, Arish, what Viji was talking, the closest semblance that we can have is our NABH quality indicators that we monitor. Karen gave examples of patient fall, pain management. So those are some of the things that we can monitor in addition to what Viji was saying. Pearl, somebody was asking for the name to repeat the tool that you spoke about.
Yeah, so this was the called as IPNG, International Index of Professional Nursing Governance. So this is one of the tools which I believe tells you how ready are you for nursing, to set up a nursing governance model, or is there a need? That's one tool. Now, this tool has undergone a lot of versions. I think the latest version is version 3. It started with some 100 plus parameters, brought down to 88, and now to 50 items on that. So that's the tool to probably to set a nursing governance model, if I'm not mistaken. Yeah.
Thank you, Pearl. One burning issue with our country, and I can very well relate to this question. The question goes, in our country with high attrition among nurses, will sustaining shared governance be a challenge? So Karen and Viji, how does attrition work out with this model that you have put in place? What is your attrition rate like?
So we've had some, challenges with the pandemic. Obviously, our turnover rate is higher than it's ever been nationally, but also what we're experiencing here. Part of that is some of the travel nursing. I don't know if you have those kind of things going on in India, but a lot of nurses leave to go take travel or per diem type contracts with other companies. So right now, about 10% of my workforce is not my own employees, which is very difficult because they don't participate in the shared governance activities. And they really are contracted. They come for 13 weeks, then they might, go on to another hospital. So that's been a new challenge for us. It's never been quite that high, that portion of your workforce that you don't really employ and you're not investing in. So we've had to really think about what does that mean for professional practice models, for shared governance. And I think if we see that this is going to continue, which I think it may, until we really recover from the pandemic, then we need to think about how do we engage those nurses as well, because they're taking care of our patients, and they're nurses too, and I want them to feel like that we really embrace them. So we really tried to shift how we think about those contracted nurses. And then when people are turning over quicker than usual, we have to think about how much investment do we make in people in year 1, year 2, and really think about how do we retain them for the long haul. And shared governance models have been seen as ways to keep people here because they do have that engagement over their practice and that kind of thing.
Yeah, so Shine, I think this is an answer to your question as well. Considering attrition, how effective would this be to sustain the model? So just want to share something that we had started at Wockhardt, and as a governance model in place with 3 verticals just to begin with. But my experience has been attrition hits us hard. So you establish processes, you establish people, you establish councils, and then when people leave, it does hit us. We have a question from Ms. Tangam Gomes, who is a very senior leader of our country. The question is, will nursing departments of hospital be willing to report nursing sensitive quality indicators if we facilitate one? Now, this is if we facilitate one, Tangam, means we have an Association of Nursing Executives for India. So Pearl, what is your take on this? You think hospitals would be comfortable reporting indicators? Are we ready for it as of now?
Ma'am, I think NABH somewhere had thought about this, though some hospitals were reluctant. But I think with ABDM coming in, Akhil Bharatiya Digital Mission, I think we will not have a choice. We will have to probably start putting certain things, because we are looking at value-based care in India, which was a concept which from US, which has come down here, over here. I know US is again challenging this model by various healthcare leaders over there. But I think this model is coming in India. And I think given that fact, we will have to start putting our indicators, putting our indexes right in, in our digital model. And we will not have a choice. We will have to go ahead. Yes, there will be resistance, but I think if you look at it, it will help us to understand. We will have some kind of a database. Now, when we're talking about magnet, we were willing to put our data on the NDNQI. If I am willing to put it on an international database, I think I should be comfortable putting it in my own country's database. I think if not, we will have to make that change.
I think that is the need of the hour, Tangam. I agree with I agree with Pearl, because when it comes to benchmarking, we hardly have any data with us. So it's the need of the hour, and we need to get started somewhere. Tangam again has a question specifically for Viji. Any criteria you use for admitting nurses to various councils?
Could you please say that question again?
Any criteria you use for admitting nurses to the various councils? You spoke about 5 councils. Do you have any criteria for getting them into the council at various positions?
So yes, volunteers are the best, but we have limitations. Like for these councils, there is a criteria. For Leadership Collaboration Council, it's only leaders, like, those who are and the managers and above are the one there. So that council is for that. Outcome Promotion Council is all the leaders of this council. So that is also blocked. So the other 3 councils, Clinical Excellence Council, New Knowledge Council, and the Professional Governance Council is the clinical nurses who are involved. Say, I'm involved and interested in evidence-based practices and research. Like, nurses they all have their own special interests. So based on that, you can represent only one representation from one unit. So you talk to your manager, this is what I'm interested in, and they come to that. The Professional Governance Council are the unit-based council chairs and vice chairs. So again, that is a criteria for them to be on the system level or hospital level councils. So become a unit-based council chair in your unit, leader of your unit, and then you'll be eligible to be that. So we have set criteria for each council membership, who will be member. And every council also has a leader mentor. They are not left there alone. They are not the voting members, but one manager or above, one of the established leader is a mentor for us, all these councils. Thank you. That's a great question.
Yeah, Dr. Elizabeth, I think we are almost reaching 6 o'clock here.
Yeah, I was just about to say that it's 5:59, it's 6, and I had promised Father Johnson we're going to stick to our time. There are some questions which I think the organizers.
Yeah, I should thank you. I should thank you so much, Elizabeth, Karen, Viji, Pearl. I was just thinking about my organization. Listening to you, what are things I could introduce in my organization. Anyway, we will take it forward. I invite now Dr. Shivakumar, the medical superintendent of Justice Hegde Charitable Hospital, Bangalore, to say the vote of thanks.
Good evening. Good evening. Thank you, Father, and good evening, everybody. It's my privilege here to be proposing the vote of thanks. And indeed, I feel that it was a very insightful deliberations that happened during this course. And of course, this has been a very important topic for the nursing as a profession, and as well as for the healthcare as a service provider. So it was a very fruitful discussions, and I thank the very esteemed moderator and panelists, Elizabeth Madam, Karen Madam, Pearl Madam, and Madam Viji George, who are there here, and they have provided their insights. It was indeed very wonderful. I strongly believe that the deliberations that have happened have at least succeeded to some extent in demystifying the very complex picture of shared governance, and trying to empower our frontline nurses to the, from bringing them from bedside to the boardroom. And of course, there were a lot of discussions which which were, of course, there were some ways which told us that the autocratic way is fine. Some said the empowerment is fine, and it all depends upon the situation. And of course, it ended up with a very positive note from Dr. Viji, that telling that this is the very fact that we are discussing it on the portal is a very positive and a positive approach and a positive note. So with this, it is a very thankful. I feel it very grateful and thankful to all the esteemed members who attended this program, and I'm sure it has helped them out. Once again, from my personal behalf and on behalf of CAHO, I once again thank each one of them for being here. Thank you very much, and good evening, and have a good weekend.
Yeah, I like to add one more name, and that name is Dr. Elizabeth David, who helped me in contacting Dr. Elizabeth and all the other three panelists. So Elizabeth David, thank you so much. So we will come up with another topic that's already shown there on the screen, that's connected to finance. That will be there in December. So we will meet again. Thank you and good night. And good day to Karen and Viji.
Thank you so much, Father, and the whole CAHO team.
Okay,
Yes.
bye.
Thank you. Bye-bye.
Bye.